Good morning, and welcome back to day 2 of the public meeting of the Physicians Focused Payment Model Technical Advisory Committee, known as PTAC. My name is Angelo Sinopoli. I'm one of the co-chairs of PTAC, along with Lauren Harden next to me here. Yesterday, we began our day with opening remarks from CMS Deputy Administrator and CMMI Director, Dr. Liz Fowler, and she offered some context on how our work fits into the Innovation Center's vision. We also have had several guest presenters share their ideas on encouraging rural participation in population-based total cost of care models. Today, we have another great lineup of experts for 2 more listening sessions. We have worked hard to include a variety of perspectives throughout the 2-day meeting, including the viewpoints of previous PTAC proposal submitters who addressed relevant issues in their proposed models. Later this afternoon, we will have a public comment period. As a reminder, public comments will be limited to 3 minutes each. If you have not registered to give an oral public comment but would like to do so, please email ptacregistration@norc.org. Again, that's ptacregistration@norc.org. Then the committee will discuss our comments for the report to the Secretary of Health and Human Services that we will issue on encouraging rural participation in population-based total cost of care models. Because we might have some new folks online today who weren't able to join yesterday, I'd like the committee members to please reintroduce themselves today. Share your name, your organization, and if you'd like, you can tell us some experience you may have had with our topic. I will cue each of you as we go around the room. I'll start. I'm Angelo Sinopoli. I'm a pulmonary critical care physician by training. Spent many years as a chief clinical officer in a large health system running a large clinically integrated network with all product lines. Most recently, I'm the Chief Network Officer for Upstream, which is a value-based enablement company for networks and primary care physicians. Lauren?
Good morning. I'm Lauren Harden. I'm a nurse by training and Chief Integration Officer for HC2 Strategies. I've spent the better part of the last 20 years focused on building care coordination and integration models for underserved populations. Currently working deeply on Medicaid waiver implementation in many rural counties, and am a founding member of the National Center for Complex Health and Social Needs. And when I'm not traveling around working with communities, I live in rural Appalachia in Kentucky.
And we have at least one PTAC committee member online. So Jay, can you introduce yourself?
Sure. My name's Jay Feldstein. I've trained in emergency medicine, practiced emergency medicine for 10 years, and then was in the health insurance world for 15, commercial and governmental plans. And for the last 10 years, I've been the president of Philadelphia College of Osteopathic Medicine, and we've operated primary care center in rural Pennsylvania, as well as we've opened a medical school in rural Southwest Georgia, Moultrie, of a town of 15,000 people. So we've got a very vested interest in rural healthcare.
Right. Thank you, Jay. So I'm going to look to my left and go to Jennifer.
Good morning. I'm Jennifer Weiler. I'm the Chief Quality Officer at UC Health in the metro area of Denver, working with one of the largest health systems in the Rocky Mountain region. I'm also a tenured professor at the University of Colorado School of Medicine and an emergency physician by training. And I co-founded our health systems Care Innovation Center, where we partner with digital health companies to grow and scale their solutions. And I was a co-author of an alternative payment model considered and approved and endorsed by this committee.
Good morning, Jim Walton. I'm currently serving as a role as a healthcare consulting. I just recently retired from a role as a CEO of a large physician IPA in Dallas, Texas, creating an ACO that had multi-payer contracts. Prior to that, I was at Baylor Healthcare System as their Chief Health Equity Officer and practiced internal medicine in Waxahachie, Texas.
I'm Larry Kaczynski. I'm a gastroenterologist by training. I practiced in the Chicagoland metropolitan area for 35 years in clinical practice, retiring in 2019. I'm currently the Chief Medical Officer and founder of Sonar MD, a company that was developed following a successful proposal here at PTAC back in 2017. For the last 10 years, I've been involved with value-based care, developing full risk contracts in the gastrointestinal space.
Good morning. I'm Walter Lin, an internist by training, founder of Generation Clinical Partners. We are an independent medical group in the St. Louis, Southern Illinois area focused on caring for the frail elderly in senior living and helping senior living organizations transition into the world of value-based care.
Good morning. I'm Lindsay Botsford. I'm a family physician in Houston, Texas, and I work with a company called One Medical. I help care for our senior practices as the chair of our ACO REACH entity. So we care for older adults on Medicare in full risk total cost of care contracts.
Good morning, Chini Puluru. I'm a family physician by trade, 20 plus years in the healthcare value-based care transformation and clinical operations space. Most recently, Chief Clinical Executive of Walmart Health, Omnichannel Care, and VP of Clinical Operations. Prior to that, I led DuPage Medical, now Dewey, a large multi-specialty group in suburban Illinois. Thank you.
Good morning. My name is Lee Mills. I'm a family physician. I'm Senior Vice President and Chief Medical Officer for Community Care of Oklahoma, where for 30 years we have operated a total cost of care capitated model health plan owned by two providers operating in the Medicare Advantage, commercial, and exchange space. And prior to that, was involved in medical group leadership, coming through a whole variety of CMMI models. Thank you.
Great. Thank you all. So with all those introductions, we'll move forward to our first listening session of the day, incentives for increasing rural providers' participation in population-based models. So at this time, I'm excited to welcome the experts for our first listening session of the day. We've invited 3 outside experts to present their thoughts on some financial incentives with the potential to improve the management of care transitions. You can find their full biographies posted on the ASPE PTAC website along with their slides. After all 3 have presented, our committee members will have plenty of time to ask questions. Presenting first, we have Dr. Alana Knudson, who is the Project Director of the Pennsylvania Rural Health Model Evaluation and Director of NORC Walsh Center for Rural Health and Senior Fellow at NORC at the University of Chicago. Welcome, and please begin, Alana.
Excellent. Thank you so much for inviting me. Next. I always begin my presentations with, why should rural areas matter to you? And I begin this because I think it provides an important context. Rural areas are not only the source of much of our food, drinking water, energy production, and outdoor recreation, but 1 in 5 Americans, including a disproportionate number of veterans and active duty military, live in rural communities, making the study of health needs and challenges of rural Americans essential to us all. And I begin with this to also provide a context about the interdependence that we have between rural and urban providers. It is critical that we address the health needs of rural Americans because they also depend on urban providers, and our rural providers work in great partnership with urban providers. And in order to ensure the economic viability of rural and urban communities, it's important for us to address the needs in our rural communities across the country. Next, please. I'm going to share some lessons learned that we've had with rural participation in some alternative payment models. One of the key lessons that we've learned is that it's very important that we include rural health experts in value-based payment discussions, not only with CMS and CMMI, but also with private and commercial payers. And this also includes rural finance experts. We have seen numerous times, particularly for critical access hospitals, that participating in some of these models makes it very challenging because of the cost-based reimbursement structure that these some over 1,300 critical access hospitals across the country operate. And so it's important to ensure that they have a seat at the table when not only designing, but also implementing. It's also critical that we look at aligning rural providers to meet population thresholds. And I think I can take you back years ago when the Medicare ACO, Medicare beneficiary attestation thresholds were too high and did not allow any rural providers to participate. And that really was the impetus to begin Caravan Health and recognizing the Medicare beneficiary attestation, for example, is an important piece in looking at how we address those population thresholds. Likewise, we need to look at how rural quality reporting programs are implemented and followed, particularly for small volume providers, both in the clinical as well as in the small hospital space. Many of the different programs are optional in rural, but we need to ensure that our rural providers also have consistent clinical quality metrics so that we are able to monitor over time the quality of care that is being provided. We already know that our rural providers are serving a disproportionate number of vulnerable people in their communities, but putting a rural provider at financial risk when many of our rural hospitals in particular are running at small to negative margins make participating in these programs particularly risky, and many of them opt not to participate. So it's important to think about how we can invite innovative ways for rural providers to participate, even given those particular challenges. I think it's also important to recognize that we have some serious innovation fatigue among our rural communities. And I'll give you an example. I worked with a number of frontier hospitals in Montana. Those are hospitals serving counties with fewer than 6 people per square mile. They implemented a community health worker program that was in place for 3 years. At the conclusion of the program, the grant funding went away. And one of the CEOs shared with me that although it was an incredibly successful program and the community greatly valued the services that that community health worker provided to the community, because there weren't sufficient funds locally to continue that community health worker position, the CEO was then hung out to dry, so to speak, because he was no longer meeting a need that the local community felt was valuable. So many rural providers, particularly those that have been early adopters, where a program has either discontinued or was altered in some way, it may be more difficult to get rural providers to participate in the future. Next slide, please. There are some considerations when we're designing these population-based total cost of care models. And as I said, it's not only important to encourage and engage our rural providers in the discussion, we also need to bring our community partners together, particularly for models that rely on our advancing health equity by addressing the social determinants, and I like to call them drivers, of health in the community. It's also critical that we determine success metrics before implementation. Another key example is that for many rural hospitals, financial viability is their #1 success metric. However, many of the value-based payment models don't include financial viability as the #1 success model. Many of these are looking for cost savings. We need to make sure that the success metrics are aligned. Likewise, it's very important to provide upfront funds, not only to support implementation requirements, but also to help our rural providers in developing transformation plans as they move from volume to value. And we've seen this time and time again as part of our Pennsylvania evaluation of the rural health model. That is one of the comments that the participating hospitals shared with us as part of that evaluation. It would have been very helpful for them to have upfront funding to be able to get these care coordination models and requisite resources in place before the model started. Likewise, it's also important to minimize the new and additional staff and financial requirements that some of these models require. As you know, many of our rural providers have limited resources, and so when we require them to provide additional data submissions, that usually requires additional staff. One of the comments that our rural providers have shared with us is please do not include models that also then require us to recruit additional staff. Frankly, we've had a long-term workforce challenge in many of our rural communities, and adding staff, particularly with expertise in data analytics, is a tremendous challenge for them. Likewise, it's really important that there is some type of technical assistance that's provided not only during the model application, but also to support those implementation and ongoing data needs, as well as being able to track progress. Next slide, please. Another consideration for our rural communities is really to look at that continuum of care, looking at the long-term services and supports, how the public health community and services connect, as well as the role of community-based organizations. One of the greatest pain points that I am hearing in our rural communities right now is with regard to post-acute care. Swing beds are particularly a concern for our rural providers, so thinking about how all of these different types of services align to be able to ensure that the rural residents have access to the care that they need, but also that they are sufficiently reimbursed to ensure that that care can be continued in those communities. Of course, it's very important that we align model implementation and performance expectations across multiple payment systems. Time and time again, rural providers have shared that there are different metrics, different expectations for data reporting, and this is really untenable for a number of our rural providers. So thinking upfront how we can align these will best serve our rural providers in participating in value-based models. Likewise, ensuring that payers are within the same model design so that our rural providers don't have to try to manage, again, different types of quality metrics, for example, as well as payment systems, because again, with limited staff capacity, this makes it very difficult to actively participate. Next, please. We also recognize that there are challenges with low volumes and performance expectations, particularly with regard to savings. And I'm going to jump down to the fourth bullet. It is critical that we recognize the relative difference between costs directly attributed to patient care, which are variable costs, as compared to costs of infrastructure required to support patient care regardless of patient volume. Those fixed costs, those are the costs that are required in order to meet conditions of participation. There are also a number of costs for rural providers that are necessary for readiness, such as for emergency medical services, and those need to be factored in, because one of the challenges that our rural communities have is that issue of surge, and we definitely saw that during COVID, as well as different types of weather and other natural disasters that our rural providers have responded to. It's also challenging to look at potential avoidable utilization reductions to reduce the overall payer expenditures, because again, this cost reduction is in the short term and it doesn't affect those fixed costs that are foundational to be able to meet those conditions of participation. It's also important that, as I mentioned before, that we look at including the recommendations from the 2022 National Quality Forum, the MAP Rural Health Work Group report that also provides important quality measures that can be used when we're looking at implementing new models. Last slide, please. It's important as well to link financial risk to performance other than cost savings. If financial risk is mandated, this is a big issue for many of our rural providers. And it's also a concern not to place essential local services at financial risk, including primary care, public health, and EMS. And again, I'll give you a concrete example. I visited a Frontier hospital that had not only the rural health clinic co-located, but also public health, and they had to move public health out of the facility. And by the way, this is a community of 1,100. The public health had to find a different facility because it played negatively into the cost report. So again, we do not want to put our essential local health services at financial risk. Also, applying financial risk only to aspects of performance controlled by the model participants is important, because one thing that we often see in our rural communities is that a patient will receive some type of surgical care or intensive medical care in an urban tertiary. They are released and they come home and they show up in the ED, for example, in a rural community. And it is important not to put those types of care provisions at risk. Also, thinking about models that don't rely on fee-for-service, again, because of that fixed cost, because of the low volume, think about opportunities per member per month, as well as other types of capitation. Also looking at reducing innovation and alignment barriers through regulatory waivers, particularly, for example, if you're looking at the chronic care management, using, for example, community paramedicine in some of our rural communities. And lastly, I have a number of resources for you at the end of this presentation. We are part of the Rural Health Information Hub partnership. We develop and design all of the toolkits that are provided to provide support for rural providers as they transition from volume to value. There's also another important slide called Am I Rural? And lastly, the Federal Office of Rural Health Policy funds rural health research centers to conduct analyses specific to the implementation of rural programs. Thank you.
Great. Thank you, Alana. That was a great presentation. Next, we'll hear a presentation from Dr. Tom Lee, who is the Chief Executive Officer of Galileo. Tom, go ahead.
Thanks for having me. My name is Tom Lee. I'm a primary care internist by training and currently lead an organization called Galileo. It's a new care model really designed to improve the quality and affordability of care for all Americans, but particularly focus on rural and underserved communities. Next slide, please. Just as context, my background, I did my medical training in the rural Northwest, so I have worked in a variety of rural care settings and have used that kind of experience to inform my perspective on how rural care could be reimagined. Most of my career has been focused on entrepreneurial activities, focused on improving the quality and affordability of care. First, at a mobile device company called Hippocrates, thinking about point-of-care decision-making on pharmacy information. Then at One Medical, thinking about how do you innovate on the primary care model, really looking at mostly urban populations. And ultimately, leading to my current journey on building Galileo, which is really looking at how do you serve last-mile populations more effectively and efficiently with a higher quality model. Next slide. Just a bit of background on how we approach care in rural and underserved communities at Galileo. We've really tried to look at care in general and break it down into the components that need to be most effectively delivered. Because care in the primary care setting, particularly in rural environments, is particularly challenging. Putting the resource where it is best fit with the right skills is kind of what the goal has been to kind of service rural communities. So what that means is we operate a digital-first model of care where appropriate for populations that can interact with a digital form factor that includes phone-based and other consultative services digitally and remotely delivered. And then we also go to the home as the other first place of care when frail and elderly patients cannot really travel to the office we really look to meet patients in the home, particularly around complex and capitated frameworks. And then we operate brick and mortar where needed as the second place of care. So it's a bit of an inversion of the traditional care model. We wanted to design a care model that could scale much more reliably across rural communities and almost by definition be less dependent on brick and mortar to do so. Next slide. We were asked to talk a little bit about some of the challenges related to rural medicine as it relates to infrastructure, but obviously there are many other dimensions and challenges well described in the presentation and preparatory materials here. But we'll talk a little bit briefly about our perspective on how we look at some of the infrastructure challenges. Obviously, there's the connectivity lens, but we also think about labor and time matching as an infrastructural related challenge. Skills matching, facilities capabilities, and payment alignment is all kind of interrelated to the underlying architecture of what creates challenges in particularly rural environments. Next slide. How we've thought about it at Galileo is really just to start to look at each dimension and solving for how do you be more effective with more patients more cost efficiently to make the feasibility of operations in low density markets more possible. So obviously connectivity can be an obstacle, but we really look at multimodality. We're agnostic to the form factor. So yes, cellular and or broadband access can be limited in some markets and regions, but the landline is also available, as are home modalities if and when needed. When we look at the next slide, please, the home modality is particularly challenging given labor and time matching challenges. And so whenever we've looked at how do you operate within low density markets, it's constantly how do you get the right supply to the right demand in the most cost-efficient manner to make the model operate, work within most payment frameworks. This is probably the most challenging aspect, we think, to rural medicine, and I do think that some infrastructure, meaning tech, data, and or connectivity solutions can help facilitate some of these labor challenges, but a discipline around matching the appropriate supply to the demand is one of the key aspects that we found to be critical to managing a sustainable practice in rural environments. And then next slide, please. The third dimension, which is related to labor and time matching, is skills matching. And obviously, there's a dearth of the right specialists in the right markets for the right communities. And so what we try to do is leverage remote connectivity, remote skills, and a team-based approach to care that can make what we call fixed costs behave more variably so that the expertise can be delivered across a broader geography where appropriate. So those are some ways that we've looked at it specific to these areas. Lastly, on the next slide, we just talk about more broadly ways to think about advancing kind of rural health and value-based care innovation across these 5 dimensions. On workforce, we really think about workforce training, workforce supply, and how do we improve the ability for the workforce to be up-leveled in any given local community given the challenges. The second is obviously member density. We think about how can partnerships across communities, within communities, further reduce the challenge to member density as a dimension to kind of consider. The third is really looking at how do you improve the regulatory and reimbursement frameworks to support home first care. We think that these are important critical aspects to care, provided that the regulatory and reimbursement flexibility is there. On a related note, the tech enablement, certainly during the pandemic, there was exceptions to payment that facilitated tech-enabled care. We would like to see those continue, particularly as we're looking to innovate into rural communities with more supportive infrastructure. And lastly, the investment, thinking about facilitated utilities or other data or tech hubs that can help facilitate the upfront investment that might be needed by individual practices or communities that could be supported more centrally. So those are some dimensions to consider. And thanks for the time.
Great, fascinating presentation. Really appreciate that. So next we're excited to have Dr. Randy Pilgrim, who is the Enterprise Chief Medical Officer at SCP Health. Welcome, Randy, and go ahead.
Thank you very much. Thank you to the committee for hosting this. Thanks to my colleagues. The next slide will give you an overview of what I want to use for my initial comments here. I was asked to comment on the unique health equity challenges, so I'll briefly touch upon that because, again, we have a very learned audience here today. I want to review the most important measures for social determinants of health and health-related social needs, and I will spend a little bit of time reviewing examples of prior value-based models that may be applicable and instructive for how we consider rural-based transformation into value-based world. And particularly, potentially how to approach integrating health equity into value-based transformation as we review those things. And then, as my colleagues have already addressed in some fashion, increasing the probability of participation by clinicians in future value-based models. The next slide just is a fundamental slide. Again, I will spend only a little time here, but I do want to point out some basic definitions and an index that I'll use a little later when I share some data. Equity, of course, is about creating the level playing field where everyone has the opportunity to achieve their full health potential. Disparities arise when there are preventable differences. So health equity models and value-based transformation really should go at preventing differences that are in fact preventable. The social determinants of health we know well now, and thankfully there are even more data and information that are growing about this, but they can yield to health-related social needs, the unmet or adverse social conditions that do contribute to the poor health and are frequently arise from those social determinants. And finally, new to some of you perhaps is the Area Deprivation Index, a zip code-based ranking of socioeconomic disadvantage, where a high number is bad or more challenging, a low number is better or less challenging. I'll review that in the data. Next slide. As we know, rural populations often experience a disproportionate challenges in health-related social needs. It's well known that rural communities are 19 to 20%, so 1 out of every 5 Americans lives in a rural environment. Although variably defined, it is defined often. Lower income, more uninsured, more elderly, more chronic disease, and so on these two sides of the same slide, I have arranged what often are sort of a Maslow's-like hierarchy. If this is the fundamentals that, in fact, our rural colleagues and citizens experience, then our models must actually get at those things. So transportation, food, and geographic isolation being the most fundamental challenges, housing and utilities and connectivity being the next layer. And you really, until the middle of the triangle, don't even get to clinical care as we would often think about clinical care per se. Most of that is very fundamental, again, food and housing, et cetera. And then insurance, I put at the top as empowering access to care, but itself not delivering the care. It empowers access frequently. Those are the kinds of challenges. So as we think about integrating health equity into value-based transformation, we have to think about those in terms of priorities and how those can both be best be met. The next slide shows that if we are to achieve health equity, proposing here kind of a three-legged stool, that equitable access to care is one leg on that stool, equitable delivery of clinical care is the next leg on the stool, and equitable transitions and continuity. This may be a framework we could consider as we think about transforming into value-based models, so that if you don't have access to care, you can't get the delivery of the care. If many have access and that's equitable, the care has to be delivered equitably to various cohorts of the population. And then where a lot of work is in the transitions and continuity. So using this as a framework, on the next slide, I do want to review the first 2 of 4 models that have given some framework for us to consider how to think about rural models and again, value-based transformation. The first model, very familiar to one of us sitting here, Dr. Jen Weiler, the Metro Community Provider Network, the Bridges to Care model, an excellent model that supported post-emergency department patient navigation, utilization decision-making, coming back to the emergency department, advanced imaging, et cetera, primary care. And in particular, this model used on-site patient engagement during an emergency department visit for those frequent emergency department patients. That on-site engagement model subsequently dealt with social determinants of health, and interestingly, also substance abuse and mental health patients were included in that model. Frequently a challenge that models, may not always include. The findings, in very brief, again, Dr. Weiler can detail this like none other, but there was a significant reduction found in post-visit emergency department visits, a significant program savings, and of importance, using the initial ED visit as a real-time engagement opportunity is particularly effective. I will get back to that in my final comments before my time is up. But thinking about how we can leverage existing resources in rural communities that programs are already investing in, for example, the rural emergency hospitals, the critical access hospitals, and other things, is really important in terms of making sure that we have sustainable systems. The second model, very different, but had similar outcomes. The global budget payment reform system that's in the state of Maryland aligned hospital revenue not with patient volume or services delivered, but with a global budget. What resulted from that was care transformation when hospitals and services, and clinical services in particular, were aligned with that. Subsequent studies found that the repeat visits to the emergency department, admissions from the emergency department, and returns at both 3 days and 9 days were positive findings in subsequent studies done by Dr. Jesse Pines and his colleagues. Lower utilization, ED returns, admission, but also some stable mortality and ICU stays showed that we were probably not adversely affecting the sickest of the sick, while we were also trying to impact the volume and services that were delivered. The findings here showed that economic alignment with hospitals can safely reduce total cost while you're working on this. Now, again, that sounds self-evident once you do this, but this is examples of how this has relatively worked well. Certainly plenty of challenges about where you set budgets and what's included or not. But there were opportunities also found to address disparities among the ED returns. So this was not a highly equitable outcome that we found. We did find opportunities. Subsequently, I'll talk a little bit about how we might be able to address that. The next slide shows something that Dr. Weiler actually mentioned in her introductory comments as well. I was also a co-author of this, the acute unscheduled care model, which has been seen by this PTAC back in 2018, approved and recommended. It was the first risk-bearing APM for emergency medicine. And while emergency medicine is frequently seen as a threat or a failure in many APM models, this model looked at how we could actually leverage an existing fixed cost, which my colleagues have already mentioned in prior comments, to reduce hospitalization, foster coordination, and reduce post-ED safety and risk events after an index emergency department visit. The waivers for telehealth, home visits, and transitional care management now being available to the emergency physician in the proposal, including behavioral health patients in mature phases of the plan. Once again, the PTAC looked at this after the rigorous review was recommended. And once again, the value here had more to do with a retrospective evaluation of whether a model like this mathematically should work, economically could work, and practically could be rolled out. The next model on the bottom part of the slide, although the AUCM as proposed to CMS was not, in fact, implemented yet, the principles of the AUCM model, using the safe discharges, patient navigation, and care coordination and quality measures, are being used now. Our group in particular, and there are other groups I know that are looking at this, are using this with commercial plans, with Medicare Advantage, and considering this with Medicaid as well. There are models that are live now, and they include various levels of risk and economic reward, along with quality measures and safety measures. The high patient engagement rates also mirror what the Bridges to Care model found, which is the direct follow-up from the physician group and the hospital after an initial emergency department visit resulted in notably reduced return visits. The patient experience was markedly improved, and the overall cost was improved. So we have some reason to think that there are some principles that might be compelling, some potential models and learnings and opportunities, and importantly also, as rural communities struggle most frequently with sustaining models once they're there because of the resource constraints, it's compelling to think about whether we can leverage existing resources in service of other objectives. The next slides will briefly note that when you use existing services, that being the hospitals that exist and the emergency departments that exist, there are equitable outcomes that might be achievable. These are, on the left-hand side, 300 emergency departments in 32 different states, showing that there are using one measure of quality, which is MIPS performance. That's only a single measure. These were 6 MIPS measures, by the way, all aggregated in terms of performance. And as you see, the rural, the small practice, the HHSA, low volume, and hospital-based practices had very similar results. We believe that that is because the patients had equitable access, equitable care delivery, and there was simply no barriers in order to get this done. And there was a good amount of data and feedback to the clinicians that occurred. Similar results happened in hospital medicine after the patients were discharged. So once again, using hospital-based clinical services may, in fact, yield opportunities for equitable outcomes. Next slide. Looked at a single area. Again, this is just some data that may be worthy of discussion. In 55 emergency departments, of which 3/4 are in rural environments, the area deprivation index was applied. Again, a ranking of socioeconomic disadvantage, where the deeper blue colors are actually the most deprived, if you will. The scale is from 0 to 10. Anything over 4 is indicated in the orange bars. And we found that in looking at the primarily rural environments, 3/4 of them, again, of the 55 are rural. The core measures, MIPS, sepsis bundle, and substance use evaluation outcomes were similar. Once again, there are structures that promote this, and the next slide begins to detail those. As we look at, again, sustaining, there are enough compelling models out there that make us think that we may be able to do something here to engage rural health providers and communities in equitable care. What are the reasons to think that that may actually last? In terms of equitable access, there is an EMTALA requirement that guarantees patients, from a federal law standpoint, access to care, assessment of an emergency condition, and stabilization within the resources of the hospital. There's a prudent layperson standard, and there's public reporting of certain measures, including quality measures. So there are things already in place that would tend to promote that. In terms of equitable delivery, not only establish standards of care, but increasingly telemedicine oversight in rural communities, but there's also certification and regulation that can apply. Again, the rural emergency hospital setting talked about how to do the certification and regulation standards so that the processes, the outcomes, and the governance are supportive on a longitudinal basis. And finally, where I think the most work is the transition and the continuity of care, increasing screening, HRSN identification, care coordination, and aftercare, frequently the issues that have to be funded longitudinally, but with waivers and other access to opportunities, those may be, again, sustainable. The next slide begins to show one potential framework for inclusion of health equity into value-based models. And the bottom bullets under each of these 3 legs of the stool that I've repeated now may be the most important. Actually, under access to care, not only did you achieve access to care for your population, but was it a representative population of your community, as opposed to a cherry-picked population or a selective population, if you weren't doing the picking, but it was actually picking for you. So in other words, if you achieved quality measures or operational measures that are in the middle column, you would actually be paid well if it was an economically at-risk model, if you applied those quality and operational measures consistently for all patient groups. It would be paid less well if, in fact, it was not. So there are opportunities to sort of risk adjust the payment, the risk, or the benefit under a model, depending on how well you serve the population itself. Under equitable transitions and continuity, frequently those will be process measures and transition indicators. But as I put in parentheses, very important to align primary care specialists and non-rural resources with those. But oftentimes the kinds of integration of health equity into value-based models has to do with whether or not, in fact, you really did assure that continuity and transitions occurred, and then ultimately the outcomes will follow. Next 2 slides are my final ones, and that is, again, this learned audience knows a unified mission and clear objectives are very key. I do think it is very important, of course, to establish what clinical objectives we are looking for. then align an operational model, then align an economic model, and then make sure that the consistent and adaptable model is a result. Consistent meaning the infrastructure and the outcomes and the sort of fundamentals are the same, but there's enough adaptability because, as we all know, rural is not rural is not rural. I personally grew up in Minnesota. The largest town I've ever lived in until recently was 2,500 people, and I spent my entire emergency medicine career practicing in rural environments, and they are all so different. I do, however, think it's entirely possible to have consistency with a model, but adaptability. Next slide summarizes what I said. Access, delivery, and continuity, the three pillars might be, again, compelling to leverage existing structures and mechanisms to achieve health equity objectives. I really think this is a frontier for consideration. The opportunity to use what we have better than we've been using it, rather than connect new, resource that, and then find that the resources dwindle over time, as does the program eventually, is a compelling thought. Thank you very much.
Thank you. Great presentation. So now I'd like to open up the discussion to our committee members for questions. To indicate that you have a comment or a question, if you'd flip your name tent up, or if you're on WebEx, Jay, just raise your hand in WebEx, and I'll ask if there's anybody that has any initial questions they'd like to ask. I can't see. Does Jay have his hand up?
Yeah, I have my hand up, Angelo.
Okay.
Yeah, this question is for Tom. I'm really interested in what you're trying to do. So do you see your company as a standalone solution for rural care, or do you kind of bolt on to existing infrastructure in certain rural communities and kind of fill in the gaps? Or is it both?
It's the way we've designed it is both. There are gaps where there aren't any providers, where we fill in gaps in networks to service those regions, and then we intentionally wrap around local providers and provide infrastructural support and other collaboration with established providers. Particularly in rural communities, we think that the fabric of care needs to be maintained, if not supported, and so a lot of what we do is help facilitate handoffs, communication with established providers and CBOs in any given local community.
And about how many markets are you in right now?
Digitally, we operate across all 50 states, and that includes just rural care digitally delivered. We do have a home-based presence in 4 states, soon to be 5. Those are particularly in rural communities, but we also can operate in urban communities. But that's the current scale that we're at.
Thanks.
So I'd like to expand on that question a little bit and maybe ask it of all 3 of our panel members. So we've heard a lot over the last PTAC meetings, public meetings, about the need for actual contact with patients, actual physical contacts and team members, and kind of a multimodal interaction with patients and how effective that is. So obviously in the rural environments, that's much more difficult to do. And so I'm hearing more about digital intervention and more about, even today, telephonic intervention, virtual intervention, certainly coupled with community health workers and mobile care. But I'm curious as to whether you see that those other interventions are actually working in the rural environments. And if they are working, what's the key to the success of those interventions, as opposed to the thought process generally that telephonic care management doesn't really work and isn't as effective as interventions otherwise? And so let's start out with Randy, and we'll work our way through.
Yeah, certainly, Angelo. So we do have some experience in our own group on this, and I'm aware of other groups that are doing the same. Once we establish, I'll use our own experience just because I know it best. Once we established a 24/7 nurse call center for the sole purpose of following up on an initial emergency department visit to assure continuity, help patients with navigation, connect them with primary care, we found that there was about a 60 or 70% rate of returning calls from that nurse center a series of 3 calls, an escalation, and so forth, just to return the call. Once we appended that with a text message, the initial text of which went out right after the emergency department visit. So patients typically in the parking lot leaving the emergency department for their ambulatory discharge, that 60 or 70% raised to 90%. So that was a much different patient engagement result. And then there were other follow-on results that occurred after that. We found that the key was simply getting a hold of and establishing post-emergency department contact with the patient. Texting certainly helped that. We were working also on a web-based interactive site that actually is diagnosis or follow-up specific for them. So those results are yet pending. I think your question is, does that work in rural areas? Yes, absolutely, it does. We are not in some of the most discrete rural areas, if you will. So we're not in Alaska, for example, where some of the connectivity and some of the infrastructure there may be more challenging, but where there are broadband capabilities, Wi-Fi capabilities, and cell phones, we found some very compelling results, and they were much more cost effective.
Yeah, great. Alana, can you comment on that?
Certainly. We actually did a study looking at the use of telehealth services pre-pandemic and during the pandemic. And one of the interesting pieces on this is that we found that the use of, for example, telehealth visits for behavioral health had a level of continuity over time, especially when we saw increases like in Omicron. We saw those peaks. However, in talking with a lot of rural providers and looking at the data, the use of, for example, telehealth visits has not sustained. It has not continued to be high in rural communities. That is not the way a lot of the current cohort of older adults in rural communities choose to access care. However, I think as we see our baby boomers continue to age that are much more digital, they have much greater digital literacy than some of our other older adults, I think we will see that shift. But I will also caution that when we look at, for example, behavioral health, we don't have enough behavioral health providers now. And even with telehealth and different types of applications, we still have waits for people to be able to access those care. So I just want to caution that there's a lot of opportunity, but we still need the workforce to be able to provide those services via telehealth.
Great, thank you for that. So, Tom?
To maybe address it a little bit, we've found that each modality has a purpose given the context and given the individual. So our bias has been to use the right modality in the right moment in time for the right patient. And so the ideal organization has a range of capabilities so that they can better use their labor in the most effective way. Because of the travel distances required, you have to be more discreet about who's traveling to whom, when, and how. And so because the digital form factor helps support that relationship in the absence of physical presence, we think that that actually complements and augments the provider's effectiveness and efficiency wherever it can be done. It's rarely for us a playbook of always A or always B, because, for example, in the first patient visit, we will go to the home by design, right? That's an inefficient, quote unquote, visit, but so much is learned, so much of trust is built that then you can form a digital connection thereafter. And then you also better understand the infrastructural limitations of the home to know that a phone-based encounter is probably going to be more effective than a digital-based encounter. So a lot of this is, I think, needs to be built into organizational muscles so that they can use the full range of connectivity devices to patients for the right purposes so that the needs can be better met in a more cost-effective way. But that's kind of our lens on it. Yeah.
Perfect, thank you. Lauren?
All three excellent presentations. I have so many questions for you. I'll start with one. So I spend a lot of time in partnering with rural communities, and it's really expanded my perception of who can do care management, who can really deliver services. So I have been part of designing models that involve ministers as the core person. So I'm curious, workforce is such a huge issue in rural. What creative roles or disciplines are you seeing step forward as key and also possible to tap into in rural? And are there any policy changes that would facilitate integration of those roles on a broader level?
I'll start. Our experience has been a surprising amount of a surprising contributor out of proportion to what we ever thought to the ultimate outcomes that we're looking for, or to interval outcomes, has been simple navigation and wayfinding. We typically use nurses, occasionally nurse practitioners or PAs, very frequently not at the clinical license level, but to do those kinds of things. And increasingly, we're finding that that's simply not necessary. In fact, we're not even sure we need an LPN at times to do that kind of basic wayfinding, navigation, appointment, achievement, and satisfaction. So it may be important from a policy standpoint to consider whether or not there are compensable actions that support ultimate continuity and transitions of care that do not require a clinical license of any kind. Again, we've been very surprised at how simply the first, second, or third step with a patient is all you need. And as we try to not become their entire healthcare service provider, but transition it to the correct one, navigation and wayfinding has been huge.
Maybe the analog for us, I agree with Randy's comments in that area. What we've been investing in is, in local rural markets, because of the lack of available skilled talent in all the markets, we've really focused on hiring local talent from local communities to build relationships with patients and serve as that wayfinder and navigator. So, call it the community health worker, but in a much more kind of advanced context. That's kind of how we've looked at labor opportunities for local markets. And the beauty is obviously they're from the local community, really understand the nuances naturally. So I agree, reimbursement architectures to support that framework are always helpful.
I would also add that community health workers are really critical in rural and in tribal communities because of that connection and that trust factor that I think is really important, especially as we're looking at advancing health equity. That is foundational. But I will also counter that with the challenges of getting those different people reimbursed. And I am at a rural meeting today sponsored by the National Rural Health Association, and that is the exact discussion that we're having. Community health workers are not always reimbursable, and yet they are really key in making those important connections.
Thank you.
Jeannie?
Thank you to the panel for the really thoughtful dialogue. My question is regarding something that Tom had mentioned, and it's to Tom as well as the other panelists. Tom, you had mentioned in your presentation a decrease of sort of the regulatory infrastructure regulations that now govern certain parts of care delivery. Yesterday it was brought up, obviously, some of the regulations around telehealth, in-person requirement, as well as some of the other things. Can you give us more details on your thought processes around this? Because given the construct of sort of the committee and our recommendation, this seems like it's something that is something we can take on.
Yeah, it's probably beyond my expertise to give the specifics. I think the general lay of the land, and happy to refer to our council, who probably has a much more specific lane of conversation around each state. So it's obviously programmatic, state-based, but they generally fall into two areas. One is about labor and workforce. So what services are reimbursable in what settings by whom? So a lot of that has to do with kind kind of what labor and workforce can be deployed into kind of which setting. The second would be reimbursement and reimbursement flexibility, particularly around digital modalities. So I think those would be the two general areas. And then, I would probably just defer to my senior team to kind of comment more specifically.
Thank you. Randy?
Yeah, it's a good question. I mean, the whole idea of telemedicine was to bring the clinician to the patient. I think anything that supports that and has the right sort of framework around it so that it's not promoting misuse or even abuse of clinical care is a good thing. So anything that we can do, as COVID has shown us, as the extension of telehealth capabilities has also been provided for through 2024, those things are generally good. Once again, I'm actually quite surprised at how at times the clinical objectives of the telehealth visit are not always as concrete. Some people just know they just want to see a doctor, and this is one way to do that. And if it's entirely patient-driven, which I'm a very big supporter of, but if it's entirely patient-driven, sometimes the ultimate objective gets lost in the setting of longitudinal care and ultimate health outcomes. So I'm a big fan of bringing clinicians to patients wherever it can possibly be done, but also aware that there have to be certain guidelines around the utilization so that in fact you don't just get a lot of care delivered, but no ultimate outcomes for that care.
I would add one place in rural that's really important to look at some of the regulatory, particularly face-to-face, and that is with regard to hospice care. Having telehealth be used instead of face-to-face, especially in the later stages of hospice care, is an important addition. You don't want to take vulnerable patients out of the home if you do not have to, and many providers are not able to go to the home. So that telehealth visit really supports not only the patient but also that family.
Thank you, Alana. That was really...
Thank you. Jim?
Thank you. Thank you for your comments. Randy, I was struck by some of your comments. I was going to kind of just do some reflection. When I was practicing in a rural area, one of the things that seemed to be recurring a lot was the emergency department in my local hospital served as a reservoir, so to speak, or an opportunity to decant patient overflow when we were overwhelmed. And we would often tell the patients in the middle of the day, please go to the emergency room because we already have so many patients to take care of. We couldn't possibly work them in, even though we had an open schedule. And what I think that I'm reflecting on, and that also happened at night, right, when we were on call taking care of folks. And so one of the things that I was struck by your data, which was the amount of equity of care delivery that took place once the patients got to the emergency room. And I really think that that was a very, very helpful piece of work to illustrate that. But one of the things that kind of comes to my mind around this idea of a value-based model, kind of if we move forward with the next idea of incorporating equity in a real-time way, is do you see emergency department activity and actors and reimbursement for emergency department activity connected to primary care so that there is a combined responsibility for chronic disease outcomes and completion of preventive care services that we know by evidence reduces the demand, the downstream demand for healthcare, and also will reduce morbidity and mortality. So in a future value-based model, would you see emergency department physicians and primary care doctors being, if you will, an integrated team, particularly in the rural areas, and being accountable for the way they receive payment rewards, being accountable for not only measuring the community's health disparities, but also being accountable for moving them or closing them or shrinking them together by some kind of concerted activity. And I think, Tom, I'd like to hear your response to that too, from what you're doing with Galileo. But I think this really kind of, you stimulated me with your comments. So I just thought we would explore this a little bit.
Yeah, listen, I really appreciate that. I would have a couple of thoughts to your comments and question. First of all, I do not think the current reimbursement environment and the realities of how we're paid in emergency medicine is aligned well. I don't think that at all. I do think that there is every possibility that, in fact, we can change that. I know the emergency department being sort of, in some sense, a safety net, a backstop, a fail-safe of sorts. It's very difficult to take a fail-safe and a backstop and turn that into an opportunity that actually does what you were talking about, which is align around health disparities and prevent them where preventable, and then make sure that the chronic care and ultimately the utilization of the system is right-sized. Our current system does not support that well. There are systems that do that in concept and in theory. The AUCM model was one of those. And I think it is harmonizable with other existing systems rather than it being standalone. So I really liked your comment about making sure that primary care and appropriate specialty care is aligned with the emergency department. I absolutely believe it's possible. It will take change from the current system. The current system does not do that well. It may also take, and I know this will be an edgy comment, but it may also take some revision of the requirement under EMTALA, which is a very high standard of assessment with a requirement of near perfection to identify a potential emergency medical condition. That chews up a lot of resources to meet that standard, when in fact you don't always have to meet that standard in order to make sure that the longitudinal care for the patient is appropriate and aligned with primary care. So I think there's work to be done here on this, and particularly in rural areas, we need to make sure that we don't trip ourselves up with existing structures, but at the same time leverage what's already there.
Yeah, just briefly, obviously this primary care ED access is an important access in a lot of communities in general. And I agree the reimbursement alignment is challenging. I think it's a noble goal. I think organizationally and financially, I think it could be complicated given the just inherent natures of the different types of services in their organizational infrastructures. But I think if you can solve for that, I think it would be interesting. The way we've looked at it is at the end of the day, people and individuals choose to go down the path of least resistance, all things being equal. And so the ED in general can be the easiest place for most people. And so I think coming up with alternatives, creating some financial alignment for those alternatives, I think can also kind of redirect patients to the appropriate resource first. Those can be done digitally or through phone-based services and or other ways to support the infrastructure of better places of care. So I think I always look at kind of path of least resistance and how do you kind of change those incentives and architectures to better support the right flows and dynamics. I do think communication between those groups is still critical regardless, and so I think something needs to kind of help facilitate that. Certainly the information flow whenever we go into community is pretty low in terms of ADT feeds and otherwise. It does take a lot of effort to wire those up. And so that's another opportunity for better communication between those two important provider types, I think, as well.
Perfect. Thank you. Larry?
Thank you, Angela. This was a very sophisticated set of presentations. I really enjoyed all three. And I jotted down a number of the statements that each of you had made. And I love Alana's comment about utilization reduction only affects variable costs. I thought That struck me. Tom, I love the fact that you flipped and had digital first and brick and mortar last, and that you want to make fixed costs act more variably. I love that comment as well. And Randy, rural is not rural is not rural. You got me with that, and I love your focus on access. My question to the three of you is, we've learned in previous PTAC sessions and different meeting dates that we need to have a proactive primary care model. I heard a lot of reactive from the three of you. What are each of the three of you doing to proactively reach out to this population that may not even realize that they need care?
I can maybe start. We participate in risk-based arrangements, and so we take accountability for populations. So I think that just the mere concept of accountability helps. And then you have to look at payment alignment and operational alignment to do so. We've designed Pop Health Services, or what we call proactive services by design, because it accomplishes multiple goals: engagement with patients, preventative care, chronic care, quality of care, but also builds trust so that when we're doing the transactional reactive care, we have better context and better nature of how to service the individual patient. So we think proactive care is an important component to population-based care in general. And a lot of the capitated and or quality programs help foster that alignment. That being said, it is very hard to do this work on a scalable basis if you're in a very busy primary care practice. And so that unwinding of time to find more time to play offense in the general community, I think, is quite challenging. And so there needs to be a tech and data infrastructure to know which cohorts have which gaps. There needs to be a reasonably scalable labor force to build, engage, close those gaps. And then what I call the appropriate clinical connectivity to the primary care team so that there's alignment with the primary care plan, not what I call kind of two different teams operating in very different environments with different objectives. So I think those are the challenges to it, but I think those are kind of some of the elements that we face in our operations.
I'll mention something next. Another great question. I really think that articulates the various roles that healthcare entities in a community play. In the emergency department, we've been classically doing absolutely nothing about reaching out to the population. In fact, it's one of the things that has held us back from participating in value-based models over years and years and years, has been our population is actually whoever comes to see us. That's 100% unscheduled, 100% patient-driven, where the patient or someone on their behalf comes to seek their care. So that's held us back, as opposed to a roster-based mechanism where a primary care may get a list, and here's your patients. Take care of them, allowing them the opportunity to reach out ahead of time. In trying to bridge that, however, there is actually an answer to, are you doing anything? In some of the models that I mentioned in my presentation, the outreach after an initial emergency department visit, because that's now our population. You came to me, now I can reach out after you. Interestingly, that outreach becomes the outreach prior to the next visit. So it's after the first one, but it's prior to the next one. That's where we found most of our opportunity, and mainly not to replace primary care, but to connect them with primary care, which of course requires that there be primary care to connect them with. But most of that outreach, amazingly, even though it's after the first event, has been effective. I think there's opportunity there, but it still does leave a gap, Larry, that I think you point out very nicely, which is what if no one ever does come? Have we seen about their health care, and let alone equitable care in the process of that? I think that's a gap that we need to think about very carefully in rural areas especially.
And I guess I also go back to finance drives function. And when you're looking at primary care and what people are reimbursed to do, I often talk about windshield time in rural, because similar to Randy, I grew up in a community of 434 people. Trying to get care out in some of those areas requires actual windshield time if you're going to go to these homes. So that is also an issue. But I just want to take you to two demonstrations that we have in progress right now. The Pennsylvania Rural Health Model is a model that funds hospitals, and hospitals work with communities. But the interesting part is that primary care is foundational to all of the work that we do and all of the outreach in being able to advance population health outcomes. So we need to have models and payment systems aligned so that hospitals and primary care and ED, everybody's aligned and going along the same path. If we have a different value structure or a different incentive for the hospital than we have for providers, we are going to have a misalignment. Likewise, when you look at Maryland in the total cost of care, it's always important to remember there is an all-payer rate that is foundational to the success of that model. And so it helps to be able to align not only incentives, but payment. And so as we're thinking about this, think about how payment needs to be aligned not only across hospitals, EDs, primary care, behavioral health, the whole continuum, but also think about the alignment across payers.
Great, thank you. Lauren, are you next? Or Cheney next? Okay.
Thank you to the team. Alana and then Tom, as well as Randy, adding on to the construct of payment reform, how do you see differences in attribution and changes that could potentially happen given that there's low density in rural areas to attribution? What are your thoughts around how that could be changed?
Well, the Rural Emergency Hospital designation that began January 1st of this year provides upfront funding for these rural hospitals. And I think if we start thinking about rural hospitals from the standpoint, or rural providers, if you will, from the standpoint that we look at, for example, police, fire, different requirements that we need to maintain our rural communities, I think we need to also think about having those essential services be available and looking beyond. Volume-based is piecemeal, so that creates a lot of trouble for those low volumes. That's what we're talking about. Those low volumes are really challenging. When we get into value-based, even when you look at global budgeting for a value-based payment model, you are also always starting at the basis of the history of what was sought using volume. And so when we're thinking about new payment, what if we think about it in a structure where you have a base payment for rural hospitals that provides incentives and accountability to address population health metrics? And not just rural hospitals, but rural providers. I talk about rural providers more holistically. As I said, it needs to be hospitals, primary care, and also those community partners as a unit. Because in rural community, these types of efforts are blurred. And we were just speaking before about ED services. I can't tell you how many rural providers share with me that their ED is the safety net for mental health problems. People show up at the ED because there's nowhere else to go, and the only place that some of our rural providers have to provide care for these folks is either through the hospital or they send them back to the county jail or the local jail facility. So there's a lot of intricacies that need to be thought through. And if we had, for example, some kind of a grant program or an upfront payment for these rural hospitals that address the population health needs, that would better suit the low volume facilities.
Tom?
Yeah, so I'll give my, again, naive lens, given that the regulatory, financial, technical constraints are beyond my pay grade. But in general, for me, the concept is in these low density markets, is there a concept of a regional utility that can kind of float above the PCP groups and or local hospital that can kind of centralize and share some of these functions more globally, similar to an IPA, but perhaps with a slightly different business intent or organizational intent. To me, it allows you to overcome these subscale issues with a common mission purpose that kind of floats outside the organization per se. To me, that's one way to start to think about it. So that there's alignment, because there aren't that many options to aggregate in a local market. You have to kind of build this consortium together, and then there's a lot of shared functions that are needed by this community. If you think back in the days of the Rio, but it's a Rio with broader services kind of concept. So that's how I think about it. We're trying to just innovate on our own individually, subscale, and that creates challenges for us. But when you really look at how do you foster and lift the communities, my guess is something that kind of helps facilitate aggregation at some level.
Randy?
Yeah, look, if this group could solve the accountability quandary, the attribution quandary in particular, I would love that. I know that's a very thorny thing to do. A couple of thoughts just to add to this. I think about attribution a couple of ways. One is accountability for care that is delivered once care has been contacted. So the patient comes to me, I've delivered something, I should have an attribution piece of that assigned to me because I did something with the patient. There may be also attribution in terms of accountability for a population, whether or not they came to see me as a clinician. And so I think being very clear, when I have approached this in the past, including my brief actuarial background, we've really been tripped up a lot about attribution with respect to a clinical event, as opposed to attribution with respect to a population for which I am accountable. I think there's a real need for clarity around that. I know in brief comments here, I'll not be able to do this, but I will say the accountability for outcomes can occur and be attributed to an accountable group, particularly a clinical group, whether or not they see the patient or not. There are some patients that self-treat and do fine, and the outcomes that we're looking for, even for some conditions, are okay. However, if I ever touch that patient, they do come to me for care, I elect to deliver care, the attribution in some fashion or another should attach, in fact, to me. And again, the intricacies of working all that out and the cross-attributional complexities in systems are pretty daunting at times. Sometimes I have found, though, that, again, as the earlier comment was, aligning primary care and acute care around attribution, something in that direction is highly important, and is very little of that, to my knowledge, is scalably being done right now. So I'd really encourage the group's thinking around combining acute care with longitudinal care and combining the attribution scheme around those things. Again, more detail, happy to talk offline if desired.
Thank you.
Okay, Lauren?
This is a bit of a follow-on question from your conversation there. So one of the things that's emerged, the deeper we get into the needs of rural, along that theme of what's most helpful in looking at this is an all-payer approach, really taking into consideration the standby costs and the need for capacity building. So one thing I've started to see across the country, it's emerging a lot related to the Medicaid waivers, but it applies in this context related to rural, is an interest and a cry for hubs. And we've heard that from other presenters. So a way to bring a community together, whether that's on a county level or a regional rural level, to concentrate and share some of those standby costs, to look at co-location, facilitate the community partnerships to build the response system for health-related social needs. And also some of that is also bringing forward a central way to address the need for technical assistance, quality assurance, data analytics, grants. So I wonder if you're seeing that as well, and any successful models emerging or recommendations related to payment for that. And Alana, you were starting to address that with the base payment. for the rural hospitals as a hub.
We are seeing some hospitals coming together. For example, in Texas, they have the clinically integrated network, and I believe they're up to 23 hospitals in Texas that is part of that, and I can share more information regarding that group. But we also are seeing it not just in hospitals and clinics, but we're also seeing it in some long-term care because of the issues with staffing and pulling together resources at a regional level so that there is a way to share those types of resources as well as to anticipate staffing shortages. And as we know, CNAs and other nursing and frankly, staffing across the board in many of our rural nursing homes is at a critical level.
I'll go next, Tom. If you have thoughts, I think one of the most vexing things, besides attribution, is the expensive nature of hospital-based acute care. And so, to your question about the funding of standby capacity, capability, responsiveness, that's expensive. It's just expensive. That's one of the biggest downsides of trying to utilize something that's already inherently expensive in order to accomplish other healthcare or outcome objectives. However, the opportunity is it's already there and it's already being paid for in some fashion or another. So as we've talked in earlier comments about modifying what you're paying for, I think there is opportunity to your comment. Again, I appreciate this. Not just to use hospital-based, whatever form they are, critical access facilities, rural emergency hospitals, or existing full acute care hospitals, and their emergency departments or their ancillary services. There's a lot of money there, and a lot of that money has to be spent, particularly in the workforce deprived areas that Alana was talking about. You got to respect that, and you have to not invade that. Otherwise, you will get upside down with that objective. But I do think there is opportunity to be more clear about what those standby costs and capabilities are for, and to expand them in service of the equity objectives we've talked about and the fuller community perspectives. I think clarity, and as Alana said earlier, I agree with this entirely, the functions will follow what the funding is for. And as long as that actually is thoughtfully done, I think there's opportunity there to leverage things that we have.
Yeah, maybe just one minor add-on to Randy's comments, which agreed. I don't know of specific examples of the hubs and otherwise, but I think the tension here, a little bit to Randy's comments about rural, like a common framework would be helpful for these, but perhaps not a prescriptive program design, allowing communities to shape the elements of them, shape the anchoring of them, the standards of them. That might facilitate a more scalable and customized, localized hub framework without being too prescriptive. Again, easily said than done, but I do think that because of the nuances in any rural community, making sure that it's not overly prescriptive, I think will help facilitate engagement and design at a local level.
And if I could just add one comment to that as well, it's really important to have some kind of a glide path or some way to provide a place of convening to determine how that hub is going to work, because the trust and the ability for these local entities to work takes time and it takes dedicated staff. It doesn't just happen. So really thinking about what is that structure and how is that structure coming together and how is it funded?
Thank you.
All right, Walter.
Thank you to our experts for just fascinating presentations. It's been a really informative session for me. My question is primarily for Tom. It is a really innovative model that you've created through Galileo. And I wanted to just raise a few questions based upon your comments and some of the supplemental information in the slides that you've given us. So in terms of reimbursement, you mentioned that you have risk-based reimbursement that is working right now, that provides what seems like really great rural healthcare. I'd love to kind of understand kind of what reimbursement model that Galileo uses to support its operations. One. Two, one of your slides at the end there talks about high acuity member management, and it just made me wonder if Galileo focuses on a certain subsegment of the rural population that are more high acuity, or is this model applicable to all members in rural settings across the board? And three, one of your slides mentioned the impact of the model, which you documented as 46% fewer specialty visits. We've heard from prior sessions just the dearth of specialists in rural areas, and I just kind of want to unpack that a little bit, whether this kind of model with much fewer specialty visits is something that works really well from a patient quality perspective. Is this something that we can use to think about in terms of maybe substituting more intensive primary care for specialty visits, given the difficulty of obtaining specialty expertise in some of these areas?
Yeah, happy to maybe clarify a bit. So the current form factor of medicine in almost any context is an office-based synchronous encounter. And so there you're blending general knowledge, specialty knowledge, a bunch of other intangibles into one form factor. With Galileo, we've tried to be more discrete about what form factor is needed for what type of care, for what type of patient in the appropriate context. And so by doing so, we have changed the framework a bit to knowledge-based care and what we call translationally based care. So knowledge-based care is what we all grow and learn as clinicians about. What we're trying to do there is improve the quality of the knowledge, the quality of the decision-making, the breadth of the interdisciplinary nature of the decision, what we call a multi-specialty lens to any decision through a digital form factor. That allows us to be more unit price efficient because the time for a provider to solve any clinical situation is more effective and efficient. Provider satisfaction is higher too. They're not spending all their time collecting information and repeating a bunch of information. So the unit price is lower, which allows us to operate within most fee-for-service environments and or risk-based environments with a preference towards risk on our side. The corollary to that is by spending more efficient care on the digital side for the stuff that can be accessed digitally, we then have more time to invest in complex care, home-based care, what we call the people-intensive side of care, where that interaction is much more labor-intensive. So we're bifurcating into more efficient care and more intense care against the cohorts needed. And so we, in any rural population, can service a low-complexity individual to a high-complexity individual. And then with respect to specialty care, a lot of specialty care is knowledge-based, and so that knowledge can be adjudicated digitally or sometimes in a situation where there's not a mobile app, a phone-based consultation. And then the physical nature of specialty care and or primary care is then typically allocated to the office. So the use of resource is better allocated to where the CapEx is, and so therefore we think that it not only improves the quality, but the affordability of the care in general, and obviously under a value-based arrangement, the alignment is there as well. It's a lot, but hopefully that helps clarify. Yeah.
It does, thank you.
So we only have 5 minutes. I'm going to end with one kind of broad question. So as we have listened over the last 2 days and with the research that PTAC has been provided, and what's been constantly in our face is that these rural and our frontier markets consist of much older patients, sicker patients. The geographies have less primary care doctors, significantly less specialty providers, less healthcare resources, less community resources, a historical poor coding activity by the physicians. And actually, because of all that, we wonder how can a practice even survive in that kind of environment, and have been actually shared with us some practices that have failed because of participating in alternative payment models that stress their practice. So my question to you all, if you know, is so how are practices surviving in these rural and frontier geographies with all of that against their success? And of the ones, are you seeing practices fail? Are you seeing them being unwilling to participate in APMs? And if they're participating in APMs and being successful, what's different about those practices that allow them to be successful in an ACO or an APM that distinguishes them from others? If you've had that exposure or can answer that. So I'll start with Alana.
I think those that are successful are more willing to take risk, and they're also innovative and they draw on their strengths. And I'll give you a great example. We worked with the Maryland Healthcare Commission on a rural health problem that they had with Chestertown. Chestertown was about to close. We worked with them and identified the strengths of that community. It has a high proportion of older adults. They were committed to ensuring that there was access in their community, and providers and the community worked together. And I think a lot of the success of the providers that are able to continue in value-based care models are because they have aligned with their community and got buy-in. People are not bypassing, they are staying local. And that is critical to any of these rural providers being able to be successful, having that community buy-in.
I'll add.
Go ahead, Randy.
Yeah, sorry. I'll add, I do think a progressive mindset when we've seen success is definitely helpful, but a real reason to invest in the community for either the clinicians or their staff or both, as well as aligning, as Alana just mentioned. Those are keys to when people have succeeded. When things have failed, what we have found is we've looked at the communities, and again, as I mentioned, 62% of our 300 emergency departments are in rural and underserved communities. So we see a lot of what happens in communities when they fail, and a lot of times the practices do not have natively the capital to invest, or at least affordable capital to invest in order to get themselves to a place where they can utilize telemedicine, texting capabilities, or other functionalities that are required that support them and expand their capabilities. So access to capital is a key. And another thing is a reasonable backstop to any risk-bearing arrangement. Sometimes there are unreasonable backstops, which are really sort of nothing, and then people really don't want to invest, and they have capability and they're already there. So again, you can't take all risk away out of risk-bearing value-based programs, but reasonable backstops that are considerate of the kinds of risks that are actually being encountered by practices are important.
Thank you. Tom?
Yeah, my observations have been, interacting with a broad range of provider groups across rural and urban environments, is the ones that are surviving tend to have leaders who are rooted in the community and are more operationally and financially savvy than the average primary care provider. I think the average primary care provider is not financially and operationally savvy, just based on the nature of our training and who we are as people. And so I think the vast majority of providers are struggling, and the ones that are rooted are figuring out a way to survive, but I think it's challenging. The reimbursement or ability to potentially uplift these practices, I think, needs to be facilitated, not necessarily just done through reimbursement, only in the sense that, reimbursement is a bit of air, but I think the structures are really the challenging aspects to most of these practices. And I think the operational savvy to do so can be challenging regardless of reimbursement. So I think reimbursement is, in my mind, just air to a suffocating provider, but doesn't allow them to truly innovate. So I think a combination of air and or structures to plug into, I think, could be a helpful formula to think about to lift the average struggling provider in the community.
Great insight. Thank you for that. So I appreciate the panelists' time. As Larry said, you've been a very sophisticated group and have given us a lot of information and things to think about. We'll have another listening session this afternoon at 10:50. And so for now, we're going to adjourn at 10:40 for a short 10-minute break until we come back. So thank you all.
Thank you all.
Produced by the U.S. Department of Health and Human Services.